Science leads us to new knowledge, and new knowledge leads us to understand the world in a better way.
I like to say that the biosphere was the original World Wide Web.
There's nothing right about giving a machine the right to kill people.
To understand the world, the extremes will not do it. We need to look at the majority to understand what's going on.
So welcome to today's event entitled, What Do We Need to Discover About COVID-19? Presented today by UNSW Centre for Ideas here at UNSW Sydney. So to begin, I'd like to acknowledge the traditional custodians of the lands on which we meet, on which UNSW's campuses are located, the Bedigal, Gadigal and Ngunnawal peoples. Pay my respects to the elders, both past and present, and extend that respect to other Aboriginal and Torres Strait Islander peoples present today. So it's lunchtime, June the 2nd, 2020, 3 months into the greatest crisis of all of our lifetimes. In fact, some people have called it a triple crisis, medical, but also economic and arguably psychological. So as we get ready to return somehow to normal, the new normal, whatever that is, we've prided ourselves here in Australia on how well we've done. There are only 3 people in intensive care today with COVID-19. Now, we're inundated every hour on social broadcast and online media with stuff about SARS-CoV-2, coronavirus, COVID-19. My head sometimes is bursting with information. And you find in your interactions that everyone's an expert. But there's an awful lot we still do not understand, and that's what today is about. Why has it hit older people particularly hard, in complete contrast to the 1918-19 epidemic? Must be more than the virus, the immune reaction, we'll hear about that. Why has it affected countries so differently? In fact, right throughout history, epidemics have usually affected not rich countries, but low middle income countries. Why is that different here? Although it's been devastating in some countries, no country has actually even come close to the herd immunity that some have trumpeted as a potential solution here. So the big question for today is, how on earth do we get out of this mess? The status quo with social distancing, closing borders, etc., is not going to cut it, even in somewhere like Queensland. So what can modern approaches, modern medicine offer us? So to address this today, we brought together 4 of the country's most eminent experts, all based at UNSW Sydney. So I'll introduce all 4 to start, and then we'll go to hear from each of them. Raina McIntyre, Professor McIntyre, is head of the biosecurity program at UNSW's Kirby Institute. And she runs a public health research program which spans epidemiology, modeling, clinical trials. She does research on vaccines, face masks, the flu and other infectious diseases, which inform national and international policy in how you control these communicable diseases. She's got a clear international reputation. That's why she's on expert committees nationally and internationally, and for WHO. And Raina's actually become almost the public face of science behind containment approaches during this pandemic. You'll recognize her very easily. Next, we have William Rawlinson, AM. Now, Professor Rawlinson's a medical virologist. He directs virology at the Southeast Sydney Health Service, a distinguished molecular virologist with particular expertise in a whole range of viruses, herpes, hepatitis, entero-respiratory, etc. And what he does is devise testing algorithms for common viral illnesses, a bit like a detective using the genetic sequences of the viruses to track them. He's on advisory boards to both state and Commonwealth Department of Health as a result. Our next expert is Professor Rebecca Guy. Now, Rebecca's Professor of Epidemiology at the Kirby Institute as well, Kirby Institute for Infection and Immunity in Society. Her particular expertise is in public health interventions, largely in the past related to HIV and sexually transmitted infections. But her particular focus is on vulnerable populations, including implementation of point-of-care testing and its evaluation. And she's got a multi-million-dollar grant from the Commonwealth on rolling this out in COVID-19 that we'll hear about. So finally, we've got Tony Kelleher. Now, Professor Kelleher directs the Kirby Institute's the overall boss, where he heads up in his own right the Immunovirology and Pathogenesis program. And like many immunologists now focused on COVID-19, his background over decades has been in HIV, where he's been a leading researcher and involved with pretty well every single vaccine trial conducted in Australia. Tony's been at the Kirby since 2005, where he's also a specialist clinician at St Vincent's Hospital, looking after patients with HIV infection and autoimmune disease. And I think you'll see a bit of a smile on Tony's face because he's put off the large grants from the Commonwealth announced by Minister Hunt today. So that's our panel. 4 leading speakers. We hope to run it after their introduction as a bit of a Q&A format. So feel free to join the conversation on Twitter. It's hashtag UNSW Ideas. If you want to ask a question, you can do there, but the best formats use the Facebook comments or the YouTube live chat feature. So last 10 or 20 minutes, hopefully 20, we'll throw some of the curlier questions that you put up online at our panelists. Okay, so now we begin, and we'll begin with Raina. Raina, I think I owe you an apology. You've been banging on for years telling us the pandemic's going to come. And we've all sort of said, yeah, sure. You're absolutely right. And you've really guided the country in many ways on how we stop getting into a huge mess. The question for you now is, how do we dig ourselves out of this?
Well, thanks, Nick. I think really we need a vaccine, and that should be, very high priority, which of course it is. I think the good news is with the kind of efforts that are going on globally for development of a vaccine are unprecedented. Never in history have there been so many people from so many places working so concertedly to develop a vaccine, and we've seen unprecedented alliances between pharmaceutical giants who've never worked together before to develop a vaccine, and all of that gives me hope that we will have a vaccine. There's already some publications of phase 1 trials that we've seen which look quite promising. And until then, unfortunately, all that we have is non-pharmaceutical measures to try and control the spread of the disease, which is particularly of interest here in Australia, where the government's done an excellent job in controlling the disease. And we need to make sure we stay that way until that time comes when we can vaccinate people. The very difficult thing about this virus is twofold. One, that it spreads in the absence of symptoms. So you cannot easily identify who's infected. And someone who could be infected may not even know they're infected. So when you're out and about, you can't easily identify who could potentially infect you. And the second thing is there's now increasing evidence that the virus is spread through aerosolization or the airborne route, in addition to the other modes of spread through large droplets and contact. And one of the studies that was done by 5 independent laboratories in the US, including the NIH and the US AMRID lab, showed that the propensity of SARS-CoV-2 for aerosolization was greater than that for SARS and MERS-CoV before it. So those 2 things make it really difficult to control compared to, say, SARS or MERS. And that's where we really need the social distancing, keeping 1 metre apart. There's been a paper commissioned by the WHO, which came out today in The Lancet, which shows that, and this is the best specific evidence for COVID-19, and it shows that keeping 1 metre distance is over 82% protective, and the greater the distance, the more the protection. So the rule that we have here of 1.5 metres is pretty spot on, and that's actually really useful for us to know that it works, and it can inform the reopening of society and conducting of business that we're all eager to resume. And the second thing is the use of testing, which Rebecca will tell us about, and Bill, and to identify every possible case. And then when you've identified cases, to track all of their contacts and quarantine them. Those are the 2 pillars really of disease control, because they will stop onward transmission. If you don't do those 2 things well, then you can have undetected chains of transmission in the community. And Australia has done really well in jumping on that and making sure we have very low disease incidence now. We just the risk of having transmission is going to increase as we open restaurants and start going to work and so on. So we just need to be on it really sharply so that we can prevent those chains of transmission occurring. The other two things, of course, are the travel bans, which we've just published a paper in the Journal of Travel Medicine, which showed that putting those bans on China back in February, on February the 1st or so, prevented a huge epidemic. So instead of seeing, I think we looked up to the beginning of March and we had about 60 cases at the beginning of March, we would have had over 4,000 cases if we hadn't implemented that ban. But we also looked at how we can safely lift those bans depending on the incidence of disease in the target country. Finally, of course, there's a question of face masks, which was also in the same Lancet study, which was just published, and I've published a commentary accompanying that in the Lancet, which also showed that face masks are equally effective in healthcare and in the community and can reduce the transmission quite substantially. So I think every country that's looking to resume activities and increased mixing of people, where sometimes people will be in situations where they can't avoid close contact, like on a bus or on a train or in an office building in an open plan setting, then wearing a mask may actually reduce your risk. And I think every country is going to have to look at this as we move on.
Brenda, can I just ask, that's great. So you've always been an advocate of masks and done a lot of research into it. I seem to recall in 1919, Sydney actually made it a law that you had to wear a mask. It was compulsory, and it didn't last long because people then smoked everywhere and they cut a little hole in it to smoke through. But how are we going to return to work on public transport, where we can't socially distance without wearing masks? Is it time for that now?
Well, fortunately, we have very low incidence of disease, but it doesn't mean it's going to be zero. And we will see an increased risk of disease or resurgence as people start mixing together. So those crowded public settings are going to be higher risk than, going for a walk in the park. And I think people need to make their own individual risk assessments as well. If you're over 50, if you've got chronic diseases, you may decide that's a suitable intervention for you to wear a mask on the way to work on the bus.
All right, good. Thank you very much. So if we can move now to Bill Rawlinson. Bill, you would have thought that the genetic sequence of all SARS-CoV-2 was the same.
I wouldn't have thought, but some people might. It's a really good question, Nick. I think that the interesting things that maybe people could do as a kind of thought message is just consider where we were in January, where we were in terms of there's an outbreak in a seafood market in China. We know that's often associated with influenza, close contact, and particularly in southern China. And we don't have information about this, and we don't in fact have any cases in Australia, and that's where we all were in January. And the first thing that we got was a genetic sequence, exactly as you say, and is that the same as everything else? And so from that we had a lot of R&D very quickly in the absence of being able to get the disease in the country, in the absence of cases. And it's really that sequence that underpinned all our diagnostics. And Ryan has alluded to the importance of diagnosis and the fact that asymptomatic cases occur, and in fact that asymptomatic spread occurs. And all of that really came out of a sequence from Wuhan, which is called Wuhan 1. And then what we've done, and in collaboration nationally, is to look at the sequence of the virus, and is it different? Exactly as you say. Is this just the same, and therefore could that underpin, for example, a vaccine design? And what we do, and what we do in collaboration with groups in every state, is to sequence all the viruses that come through from infected people. And in our lab, that's about 1,400 now. And we look at the comparison between that with the original strain, and it does change. And in fact, the tendency with viruses during a pandemic is to move away from a more severe illness towards causing less severe illness but more spread. And so what we're now tracking is whether that's occurring and where that might be occurring. That information, of course, is very important for vaccine design. And particularly in Australia, that information is going to be very important for determining where an outbreak is. Because the viruses are so different and because they are changing with time, we're now able to look at individual cases and say, are they closer to each other than to the original virus or to other viruses that are occurring? And therefore, are those two cases more closely related? And the really good it's almost unanswerable. If two people had the same SARS-CoV-2, which is the virus name for the COVID-19 disease, if two people have the same sequence, then they've been infected either by each other or by the same source. And that's a really important, all the other information about contact and those things are really important, but this is a single critical piece of information, and that's what we're doing. And so you can use that both at an individual level as well as at a spread level. So we're looking at spread around the country by comparing those sequences in real time. And in going forward, that's only going to increase and only going to enable us further to stop spread.
Bill, thanks. That's very clear. So there's something I think out of Israel the last couple of days saying that using genetic sequencing, that only a tiny percent of cases, 1 or 10%, will infect 80% of people. So that sort of points to the sort of super spreader type issue. I mean, can't we just work out what the molecular basis is of those that spread, wildly from those that don't?
Again, a really good question. Unfortunately, it doesn't happen like that. The sequences vary slightly, and sometimes those sequences are in a critical part of the genome of the virus, which means that a critical change occurs, such as in the way a virus binds to a cell or something like that. Sometimes it's as simple as that, but then sometimes it's that there are multiple changes across the genome. And so it doesn't appear that so far we've found a single element that is associated with more spread or less spread, although there are some areas that we and others are working on where that does seem to be more likely to be associated with spread. And of course, that may well be a target for either a therapeutic, antiviral, or a vaccine.
Good. Thank you very much. So now we go to Rebecca Guy. So Rebecca, you're driving quite a different approach, I think. Do you want to tell us about it?
Sure, thanks, Nick. So as mentioned before, testing is essential. It has been essential, but it's even more essential going forward in terms of the response. And I guess when you look at it, I think every Australian should have access to good quality laboratory testing. Bill runs a lab, and if you're in Sydney, you can get the results, I think, quicker than 24 hours. But if you're a person that lives in a remote Aboriginal community, without point-of-care testing, often the results can be delayed by 5 days or more, and that's simply just because of physical distancing. And so one of the tools that the Australian government has invested in as a strategy to help prevent outbreaks in remote Aboriginal communities in Australia is point-of-care testing. Point-of-care testing, it's different to what you've heard in the media about rapid tests. So point-of-care tests, the one that's been approved by the TGA, enables you to detect COVID-19, and it informs clinical and public health responses. And that's different to some of the other tests you've heard about, which are really picking up antibodies. So they don't change the clinical and public health response at that time. The program is funded by the Australian government, and the Kirby Institute is the technical manager in partnership with the Flinders International Centre for Point-of-Care Testing. It's a very collaborative project in partnership with many Aboriginal organisations, governments, and also importantly laboratories. And it's overseen by the National Aboriginal and Torres Strait Islander COVID-19 Advisory Group, which means it's led by Aboriginal and Torres Strait Islander people in Australia. So what the program aims to do is to provide access to remote Aboriginal communities via their health services with these point-of-care tests, which have been approved by the Therapeutic Goods Administration. And this enables the health services to get results for a patient within 45 minutes. And the reason why this is important is because of the context of many communities where there is significant overcrowding because of housing shortages. So with a delay in a laboratory test, even if the laboratory test is positive, that can mean just in a matter of days there can be more transmissions which occur in the community. And this is important because in some of the communities there's very high rates of comorbidity. But even if the test is negative, then the point of care can have value as well, because a delayed negative laboratory test may mean that that person who attends the health service, if they're considered to have a high suspicion of COVID, may be evacuated from that community. And this has social implications, cost implications. One evacuation can cost up to $20,000 per person. The point of care assay that's been used is what's called Gene Expert platform. So it enables you to test for SARS-CoV-2 or COVID-19, but also you can conduct other tests on the platform. And we've been using it in a program for sexually transmitted infections, another collaborative project for more than 5 years. The program is going to be rolled out and it's currently underway to 85 remote health services across Australia in very remote locations. And those health services have agreed to act as hubs for other spokes, which are smaller communities. So when you add it all up, point of care testing would be available to around 150 remote communities in Australia. And you may have seen in the media just recently, the first test, which was conducted a few weeks ago, received a little bit of excitement. There was a bit of excitement from the health service. The first test was in a patient who was going to be evacuated, and the negative point of care prevented that evacuation. So it had tremendous benefits from both the patient, the community, and also the health service. So I guess as part of this program, what we're intending to do is to conduct a comprehensive evaluation to really understand how point of care can make a difference in those remote communities, the additional benefit that would be achieved through access to the technology, to look at the cost associated with it and the effectiveness. This can inform guidelines and action plans, but not only in Australia, but other countries. The technology that's being used is similar technology that's been used in many lower middle income countries. And I guess because of that, the technology is in high demand. So therefore, lessons, I guess, that we learn and experiences that we have in Australia do have relevance for other countries. And I think importantly too, the experiences will be important for the future. We hope there isn't another pandemic like this, but the information can be used to inform future preparedness. And probably I think it's very important as part of this is the capacity development and the infrastructure that has been enabled through the investment from the Australian government in provision of this technology. So these 85 health services will gain access to a platform that they'll use as part of COVID-19 response, but they also will be able to use it for sexually transmitted infection for testing and treatment, and perhaps in the future for human papillomavirus, which is detected for cervical screening reasons, perhaps even hepatitis C in some areas, and there's a whole range of other things it could be utilised. So it provides services with additional benefits in regards to being able to do testing on site for SARS-CoV-2, but also other infections going forward.
Fantastic. So we're hearing it's sort of a model for rolling out in communities, as well as a model possibly for rolling out for other viral diseases in future. Rebecca, I want to ask you, so I've heard that I can have coronavirus, but a negative result. What's your accuracy like, and how does it compare with all those huge machines Bill's got?
I think Bill would agree with me. The actual technology that's been utilised in these remote communities is nearly 100% concordance with the laboratory tests, and it's the only one that's approved by the Therapeutic Goods Administration for point of care use. So very accurate test. Of course, any test you do, it depends on the timing of the specimen. So the test is accurate, but of course you've got to take into consideration the time that the person might be exposed and also the symptoms. So you can get a negative test if you take the specimen too early after exposure. But the test conducted within the right time frame will give very good concordance with the laboratory test. And in fact, in many regional laboratories across Australia, there's also been an expansion of molecular laboratory tests to even expand access further, and we're working very in partnership and collaboration with many of those regional laboratories, and they've also taken on board the same technology and put it inside their laboratories as well. So that I think gives good confidence that if the laboratories think it's a good thing, then I think we could all say it's a good thing.
Great. Okay, thank you very much. Now we go to Tony Kelleher. Tony, there's a whole range of potential weapons to use against COVID-19, from vaccines, antivirals, various repurposed drugs, etc., immune therapy, Chinese herbs, etc. So where's the money, and what are you people working on?
Well, we've chosen, thanks Nick, we've chosen to look at immunotherapies and particularly antibody-based immunotherapies. And we've done that for particular reasons. One, we have the expertise to take these immunotherapies from the bench right through to the bedside and advise on how best to use them with the expertise within the Kirby. But the other reason we've focused on this is we think antibodies are going to be very important in the defense against this virus. Some of the stuff that Bill talked about earlier about the viral evolution, we know that the virus or viruses like SARS-CoV-2 mutate away from this sort of immune response, which suggests that it's very important. So if we use antibody therapy, we have experience with that in other diseases, and so we know how to use it. We know that in general that it can be used safely and how to deploy that. And it has adaptability in that it can be used both as a potential therapeutic, but also in certain circumstances as a preventative measure as well that will last perhaps up to a month. So we think that this is a very adaptable mechanism for developing therapy with a rapid pathway of development to get into clinical trial to see whether it's useful or not. And there are two ways of doing this that we're pursuing. One is to take people who have recovered from the disease, identify those people with high levels of what we call neutralizing antibodies. That is, the antibodies that prevent the virus getting into a cell and infecting that cell. So screen for those in the laboratory, identify those people, purify the plasma from those people and concentrate that in large pools that then can be given to people who are at risk of infection or in the early stages of infection to prevent the progress of that infection and keep people relatively well. So they're infected, but we stop them going to intensive care where we know the outcomes are often very poor. So that approach is called hyperimmune globulin therapy, and we're currently screening plasma in concert with Bill, in fact, in the laboratory for people that have high levels of these antibodies. And of course, these people now exist in our community. They've recovered from the illness and are well, and we're trying to understand how long those antibodies last and who has those high levels of antibody. The second way is slightly more specific and is called monoclonal antibodies. And when we take convalescent plasma or plasma from people who are recovering from the disease, they have a range of antibodies that might neutralize the virus. This is identifying particular antibodies within that pool of antibodies that have particular potency against the virus and prevent, in a very potent way, the virus getting into new cells. If we can identify those antibodies and the genetic code for those antibodies, we can then engineer those antibodies and make them in the laboratory to very high levels in a very purified fashion. And these are called monoclonal antibodies. They're from one clone of B cells that normally make these antibodies. So the idea is to use these as a very specific therapy or perhaps prevention. And we're pursuing that in concert with the Garvan Institute that has experience in developing these for cancer therapy. The reason we think we can do this rapidly is because, as I said, those responses exist. We have a lot of expertise in this, and we understand the developmental pathway for these sorts of immunotherapies. And we think we can get these into people relatively quickly. And even if we have a controlled epidemic in this country through the networks that the Kirby has for doing clinical trials elsewhere in the globe, we feel that we can contribute on a global basis if we get good hits with either the hyperimmune globulin or the monoclonal antibody therapy.
Thanks, Tony. So this sounds really cutting-edge stuff, and it's been selected in the announcement today as, some of the Australian approaches at the very forefront of advances in the disease. So we wish you luck on this. Tony, you alluded to it though, but because Australia and New Zealand have done so well, doing clinical trials in this country is a problem now, even for testing.
So I think it's a good problem to have. And I think we can. So I think we need to take this seriously and think about where we have advantages over other areas that have clearly very stressed healthcare systems. And so I think we're in a good position to do particularly the early phase trials, the first in human trials. People will be happy to volunteer because they'll more likely come out of their homes and because they feel they've got less chance of being exposed on public transport and those sorts of things to get to a clinical trial site. So I think we do have advantages here. And furthermore, we've got a healthcare system that can do the clinical trials rather than being constantly chasing the treatment of the next severe case, which is certainly going to be the case, I think, going forward in Europe and the US. So I think we can complement the efforts there, do the early phase development there, and then hand the drugs over to them to test in the much larger populations of infected people that they have. But we will also then be prepared if we do have a second wave or a third wave, and we do have large numbers of people, we could rapidly move to adapting those clinical trials to the local environment.
So if we throw it open then, I read somewhere that it's almost 500 million, the number of comments left on sites questioning the whole science around coronavirus. There was a survey last week that said, amazingly, that 12% of Australians thought the virus was transmitted via the 5G network. How are we going to educate the public even more? Raina, do you want to kick in first?
I think it's maybe a bit more challenging in Australia because the reality of it hasn't been apparent to most people. Whereas if you've been in a city like London or New York or Mumbai right now, you'd probably know people who've died from it, or your neighbours or your friends, your family. The reality is much more present. So I guess and a lot of people, I guess, are just waiting for their lives to resume as they were. And I think we just need to bring people along with this in this journey and make sure that they understand the trade-off for that freedom is some degree of restriction, such as spatial distancing, only a certain number of people being able to go into a cafe, etc. That these things are a necessary trade-off, but there is light at the end of the tunnel. And I think finding that way of engaging people and bringing them along on the journey so that they are part of the solution and feel like they are also being listened to is really important. If you don't do that, that's when you get the wild conspiracy theories and the kind of, splinter groups forming that are pushing all kinds of strange ideas.
Yeah, sure. I understand there's not much of an anti-vax lobby in the Democratic Republic of Congo and places in Central Africa where they, understandably, as you say, take it very seriously because they see the mortality. Anyone else want to come in there?
So I think, I think getting the community involved with the response, I think, is very important, because if you can do that, then they have some understanding and some buy-in. And so I think, the outreach into the community, like the initiatives that Rebecca's taking, of taking the science into the community, and explaining to them why you're doing this, why it's of value, and then showing in the community that it has been of value, preventing those evacuations, I think allows, the community ownership and trust in the science. And, I think that's a model that we need to, that we've learnt from other infectious diseases where there's always a lot of stigma. And so if you can normalize that stigma, if you can remove that, and involve the community in the response, then you're less likely to get resistance to the interventions, and also less likely to get these sort of conspiracy theories.
Okay, that's good, thanks. So if 50% of infections are asymptomatic, I could easily have had it. I'd like to know if I've had it. So why can't I have an antibody test and then have a passport that'll allow me to travel anywhere? Rebecca or Bill?
So I'll kick off. I guess it's very important that we acknowledge not only what we can do with our testing, but what we can't. And back to your previous question, it's important that the science is as good as it can be, but sometimes the science is not 100% because we're learning. In terms of antibody and immunity, that's a really important area, and it's something that's on everybody's mind, particularly those who our laboratory has diagnosed a child in their family with COVID-19, with SARS-CoV-2 infection, and they're then locked down for 14 days. So we take that very seriously, and we take the idea of immunity very seriously, but the reality is that we're learning a lot about the immune response. Respiratory viruses typically aren't something that we use antibody testing as a measure. We do a bit in influenza, but it's not a great measure, and it's pretty obvious. If you breathe the virus in, most of your response is local. It's not so easily detectable in your blood. And so we have to do fairly sophisticated things in order to detect it in the blood. And what we now have is a number of antibody tests which are getting better. We have a lot of work done at the Kirby Institute collaboratively between our diagnostic testing, which is very much focused on the individual and on using commercial tests, and at the Kirby a lot of research around using research tests to inform that. So the short answer is, just because you've got antibody doesn't necessarily mean that you are not going to get reinfected, although we think it's a pretty good surrogate for that. Secondly, that antibody probably doesn't persist for life. It most likely persists for 6 to 24 months. And thirdly, the tests that we do have really have been developed over the last 6 weeks. And so we've been testing them on people we know who are infected, and they're detecting it pretty well. And they're detecting what we call neutralizing, which is kind of virus-killing antibody, pretty well. And we need to do more research into that to show, to get pretty well to as close to 100% as we can.
Rebecca, thanks. Rebecca, do you want to come in? Could we not combine nucleic acid and antibody testing at the point of care, especially as we're going to have to do it repeatedly?
Look, I don't think that might be the way to go, but there is, I guess, for other infectious diseases scenarios where you might do both at the same time and interpret them together. But I think, as Bill mentioned, there needs to be a bit more work done on the antibody test first. When you think about, so HIV is another example when there's been considerable work on optimising the HIV antibody tests, and that's been over a long time period. I guess we're in infancy. Australia and all countries have responded rapidly to try and gather evidence about new technology, about face masks, trying to do the modelling. All of it has been, exceptionally speedy, with high quality, but responding. So I think it's too early to be proposing that, and I think, as Bill mentioned, there needs to be more work on the antibody tests, really looking at them in a dedicated way. And I know that the Doherty Institute in Melbourne have done a lot of work on some of those antibody tests, which has been in the media recently.
So Nick, one of the spin-offs of the sort of immunotherapeutic work that we're trying to do is that we will understand what whether those antibody responses are really important, and we may be able to then use that knowledge to develop better diagnostic tests or monitoring tests that would allow that sort of reassurance that you are immune, or in fact you're not immune to the virus. So that is at least months, if not years off, before we would be able to develop as sophisticated a test as that was for general consumption.
And maybe just to add to that, just to, I guess, share some experiences. When the rapid antibody test did become available, it does create a lot of confusion within the community, which many of us have faced on this seminar and more broadly in Australia, and a lot of confusion within the community as to the difference between the tests. So if you think about a point-of-care test and a rapid test, for most people it's difficult to determine or understand the differences between them, when really the point-of-care test will, detect virus, and the antibody test detect a past exposure and your immune response. But to be able to has been very tricky, and I think there's been a lot of media about it, which some of it may have been helpful and some perhaps a little bit unhelpful. So I think there's also a little bit in going forward, as Tony mentioned before, any new strategies, you really need to think about the communication side of things as well, in addition to the how to understand them and take them up and make sure that they're used in the most appropriate way. So
So I'm missing that. I'm not sure if anyone else is, just on a technical hitch. Rebecca, thanks for that answer. We just missed the last bit of it. We're going to go to the audience very shortly for questions. So if you haven't put them in already, please submit them for any of our panelists or the whole lot on Facebook comments or YouTube Live. So just last question for me. 100 years ago, we had here in Sydney, a second wave and a third wave. It looks at the frequency of infection in Iran at the moment like they're really having a resurgent second wave. So, Raina, what is a second wave and how do we stop it?
So I think people are using the second wave terminology because it was used in the 1918-19 Spanish flu pandemic, where the phenomenon there was that there was a first epidemic wave, and then about a year later or within the next year there was another wave. Often that was more severe, and there were some countries, particularly isolated islands in the Pacific. There was an island called Tristan da Cunha where people actually got infected twice, in the first wave and in the second wave, so they didn't build up immunity between those two waves. So I guess people are thinking, well, we've had some epidemic activity in Australia. It peaked in the end of March, and now we've got very few cases. Are we going to see another rise and a peak? It's possible, particularly as we start opening up things and people are mixing more together. But if we maintain meticulous surveillance and testing and contact tracing and quarantine, as well as keeping the borders closed to countries with high disease incidence, we may not see a resurgence, is the preferred term, to a second wave. But however, there's been a couple of studies, including one that came out of Harvard University that looked at what would happen if there wasn't a vaccine in the immediate future, and they modeled multiple waves between a 2 to 5 year period. And that relates to the immunity as well, that people talk about. I mean, the term herd immunity has been bandied around in a very misinformed way. It's a term that comes up from vaccination, not from natural infection. If natural infection got rid of infections, we wouldn't have measles. We wouldn't have needed to vaccinate against smallpox. It would have just eradicated itself. Unfortunately, that's not what happens. You just get these recurrent waves of epidemics when you don't have a vaccine. And I guess very few people have been infected, even in countries with very high rates of infection, where they've tested the immunological profile of populations with serology. At the most, about 20% of people, say in a city like New York, have got infected, which means the majority of people are still susceptible to the infection. We don't know, as Bill said, how long the immunity lasts. We do know from SARS-1 that it lasts about 16 months, wanes substantially by about 3 years, and probably down to almost nothing by 6 years. And this has only been around for 5 months, so we don't know. So there's a lot of uncertainty that could influence that potential resurgence.
Okay, so very important point about herd immunity being a vaccine concept. So look, we go to questions from the audience, and there's a really topical one here that any of you can answer. How will protests, presumably the US, have an effect on the rates of spread?
It's not good at all. You're getting congregations of people in a country which has had really bad disease control. The US has had the worst disease control of all countries to date, in terms of really being unable to flatten the curve. Some cities have achieved some flattening of the curve, but in terms of the number of cases, the number of deaths, obviously it is a very large population as well. So there's a lot of disease still there in the US. And in that context, it's very different if we had protests in Australia today, because we've got low rates of disease. So there's already a background of substantial disease transmission. And on that background, those protests, I would predict, would result in epidemics in 2 to 4 weeks, maybe a bit longer.
Tony, you want to come in as well?
No, I was just agreeing with Raina. I think we know that social distancing is really important. It's not going to happen in those protests. The risk of with people vocalizing and under physical stress, they're more likely to generate aerosols than otherwise. So the particles are likely to travel even further, and these people are condensed. I think the prediction would be that exactly what Raina said, that in 2 to 4 weeks' time, we'll see a spike. And unfortunately, it will be in those vulnerable communities who are protesting, who have already taken more of the burden in the US than the other communities.
And interestingly, we're seeing mass gatherings in New Zealand as well. And I don't know if they really do have 0 cases or whether there's some undetected, but that could set them back as well in a country like New Zealand.
Okay. So there is a question here about travel and things. Now, quarantine on arrival, borders closing have been very important in Australia. But how do we see flying on a 24-hour flight with a full plane?
Travel is a risk factor, because there are so many countries with poor disease control. If you look at the WHO situation report, the epidemic curve is on the way up. Okay, it's not coming down, it's on the way up. There's more and more disease. And you don't know, if you're catching a flight, say from Sydney to Singapore, you don't know or Singapore to Sydney, you don't know where the people getting on that flight have come from. They're not all from Singapore. Some would have come from London, some would have come from somewhere else, etc. It's very hard to track. And, sitting in a plane or being on a cruise ship, any sort of closed environment where you're with people from all over the world for a long period of time, with despite the improvements in ventilation protocols, etc., and use of HEPA filters on planes, it's still a risk. Even just being in an airport is a risk, because you're in crowded lines and queues with lots of people from all over the world. You don't know who you're having contact with.
So, Nick, our lab's been testing a lot of people coming into Australia, and one of the important things that we all know is that a lot of the cases early on, and in fact continuing, have been imported. It's about 2 to 1 overseas acquisition versus local acquisition, or even towards 3 to 1. And so one of the important things is what's been done at a pragmatic level, which is to quarantine, test rapidly. We can either test, as Rebecca said, at the bedside. if that was possible, that'd be the best way of doing it probably. But at the moment, the specimens come from people who are in hotels typically and isolated. We test, we have a turnaround within about 12 to 18 hours, and then those people are diagnosed as infected or not. That sorts out a group of people who have symptoms or no symptoms and a diagnosis. The other groups that Ryan has mentioned, in terms of those who may be acquiring it on flights or acquiring it in airports, of course, won't be picked up routinely by the sorts of tests that any of us are doing.
Okay. There's a question just coming here for each of you. So are each of you in favour of wearing masks in public for others' protection? And have you actually worn a mask as yet? Start with you, Rebecca.
I'll answer the second part, Nick, and I'll defer the first one to Raina, who's an expert in this area. But in terms of wearing a mask, I haven't, because I haven't been outside the house. I've been stuck inside for 2 months following due diligence, and so therefore haven't had the opportunity. But in terms of the science, I think you've got Raina McIntyre, who's an expert in this area, who can very competently respond to that question.
Let's go to Raina last, because she publishes widely on this. Bill, have you worn a mask?
I've worn a mask purely in a professional capacity, because every day I go into the lab, and ideally we would have isolation and the opportunity, but of course laboratories are not always the largest, and so what we do is actually have our group split into two, so that if one group, they're blue and white, they wear different coloured gowns, they all wear masks to do their work, and when I approach and interact with them, I actually wear a mask in my job on a routine basis so that I can't spread from one group to the other. So yes, I've worn a mask, and I think there are certainly indications where you need to do that, and that's been alluded to before, where you can't avoid crowding, for example.
So I've worn a mask. So about 2 weeks ago on a Monday morning, I woke up with a sore throat. I presented to St Vincent's Hospital for my swab, and on entry to St Vincent's Hospital, I donned a mask to protect everybody else. And I presented to the staff clinic, had my swab, and I was negative, and so I wore the mask while I was in the hospital, and I went home and self-isolated until I had that result. And I would do so again.
Thanks. Raina.
Yeah, I too, like Rebecca, haven't been out very much, but I have done a few small stops at the supermarket, local supermarket, when I'm out walking my dogs in the morning, and I wear gloves and a mask. You know, it's from everything that I've read, it's aerosolized, it can persist in the air for quite a while, and if you have risk factors, you know, I think there is certainly evidence that it can prevent in high transmission settings from people from acquiring it. But also, more importantly, there's evidence that it can prevent people who are asymptomatically infected or mildly infected from onward transmission. There was a study published in Nature on seasonal coronaviruses which showed that people can just breathe the viruses out. You don't even have to cough or sneeze. You can just breathe the virus out, and that the coronaviruses are much more likely to be aerosolized than, say, influenza or rhinovirus compared to other respiratory viruses. And if you pop a mask on, it stops it completely, stops it from coming out.
Okay. So another question just coming in asking us about the assumptions, how robust they are, that govern the modelling we use to predict rates of case number growth.
Well, the assumptions, you know, can vary hugely between models. Some models do not consider asymptomatic transmission, and they're going to give you a much more optimistic outcome. At the very early stage of the pandemic, we saw models coming out that were wrong. You know, they predicted the peak in China months out. You know, there was one that predicted the peak in April. The peak actually occurred in February. A model is only as good as the assumptions you make and the parameters you put into it. And to do that, you have to keep reading the literature and being up to date on all, because the knowledge is changing. Every day, you know, the knowledge is changing. And if you're not across all those changes, then a model that you built, a month ago may not be fit for purpose today.
Yeah, I think we've got, is it 5,000 papers published a week? Rebecca, sorry.
Yeah, I guess just in terms of the modelling, just to reiterate Raina's point, but I think what's quite unique in this circumstance with modelling is often you do modelling and you don't know what it's called the counterfactual, or what would have happened if you hadn't implemented the intervention. And I guess what we have in the world is, it's a lot of case studies across the world where, unlike other modelling, you can actually clearly look at other countries. They're not exactly the same in terms of the healthcare system or the responses, but there's some which are very close. So in a way, you've got that natural counterfactual from other countries. Raina's right, like the modelling does assume and takes into account the latest available data, but I think my understanding from the modelling is, they were rapidly updating and enhancing the models every day in response to queries from the government, really trying to take on board the best evidence possible. But I think simply the way I look at it is you just refer to other countries, and I think it's pretty obvious what would have happened. And you can look at the nitty-gritties of it. Would it happen? Would have been 10% more, or 50% more, or 100% more? But I think the big picture of it is that it would have been much worse, and that's seen elsewhere.
Okay.
And you can validate those models and check them against the actual epidemic data that you're seeing, which is one way of kind of checking how good your model is.
So we're coming towards the end of our hour, but there is one question that I think could go to each of you, just to conclude. So in turn, what's the key gap in knowledge in your own area you would like to see solved, straight away? What's the missing link you really need? Phil, do you want to go first?
I think the key gap for me is this question about post-infection immunity. I think that I'm a virologist, but we, of course, work closely with immunologists. And the real question for me is, are you immune post-infection? If you are, for how long, and how do we measure it? And I think if we could answer that, then we could establish a population of immune people, and we could give some guarantees, because that would also inform reinfection. So that's the big question I'd like answered. And I think that a lot of what we're doing, a lot of what Tony's doing, a lot of what people are doing internationally is working towards that, because it also then informs vaccines, clearly.
Great. Rebecca, key gap.
Yeah, I think it's not a gap related to point of care, but I guess a question that I get asked just about every day in my usual routine life, and it's why were children largely unaffected? Why the difference between children and adults? And I think that's a very pertinent question, which I know will be a focus of many studies going forward. And there has been some information that has been made available through some work by the National Centre for Immunisation Research and Surveillance, but I think that there needs to be further investigation of that topic. I think it's critical to understanding the disease epidemiology, responses, schooling, anxiety, teachers' concerns, parents' concerns, etc.
Raina.
I think there's a lot of gaps. It's not just one gap, because this is still a new disease, and there's so much we're learning. Things that we didn't know about in March, we know about now, like the vasculitis and the clearly vascular nature of the clinical syndrome, even in the lungs. I think one of the questions is about the long-term sequelae of the infection. So with SARS-1, if you recovered, you went back to normal. There's now accumulating evidence that that is not the case with COVID-19, that a lot of people are left with substantial deficits, whether it's from having strokes or gangrene in the legs or even cognitive decline. I think we're going to be learning a lot more about this over the coming year or two.
Okay, thank you. And Tony, you're going to tell us about cures?
Well, I guess prevention is better than cure, and so I'd sort of echo a little bit what Bill said, but take it to vaccines. And, you know, is a vaccine possible? What are the critical components of the immune response, and can we induce that? You know, we don't have a vaccine for any coronavirus. And, you know, some of the vaccines that have been developed for other coronaviruses, you know, in animal models have made things worse. So I think critically understanding what the critical components of the immune response are and how we can induce those through a vaccine is really a very big knowledge gap. And we'll get information from that, from the multiplicity of vaccines that are being produced at the moment, and also the natural history studies that are ongoing.
Right. On that note, that's a strong note to end on. The clock has just struck 2. So if we can thank our audience then very much for tuning in to what do we need to discover about COVID-19 today. I would like very much to thank each of our 4 panelists for their time, their insights. It's really been very instructive and we've learned a lot. And just finally, if you need to learn or would like to learn any more about our events for the UNSW Centre for Ideas, please subscribe to the Centre for Ideas newsletter. And with that, good afternoon and goodbye. Thank you, everyone.
Thanks a lot.